Hello everyone, and welcome to our very first lecture for the Issues in Aging Caregiver course. My name is Amy Clark and I will be your instructor for this semester, and I really appreciate having you all in class, and I look forward to listening in on the guest lectures that the graduate students will be providing and also hearing what you have to say about the issue of caregiving. This first lecture is going to give you somewhat of a historical look at caregiving. Although you'll be able to see we don't have any clear documentation of really how caregiving has evolved, more so of what the statistics look like and how they coincide together. So this first slide that I have here for you was published in 2015, and it really talks about the magnitude of the number of people that are providing caregiving services unpaid to people in the home. So this valuing the invaluable, and it's also listed as a supplemental article for you to read in this first week and first module, really talks about how there's definitely progress towards looking at and taking care of caregivers, but we definitely have some big gaps. And as the data suggests, in 2013, there were about 40 million family caregivers in the United States alone that provided at least 37 billion hours of care to an adult who had limitations in their ADLs, or their daily activities. This estimated cost is really what has driven most of the initiatives, some of my own research and grants that have been funded, but really how we can take care of these individuals who are essentially unpaid in their very strenuous work. The first slide I'd like to show you with this particular graph looks at just the history of aging care and the elderly population ratio. So if you were to look at this, what we're looking at is back from 1960, and along that bottom line you can see those arrows. And again, if you look back into history, families truly were responsible for the caregiving of people. And if it got to be to a point where the families were unable to care for their loved one, then they were institutionalized. And so at this point in our history anyway, you can see some initiatives starting to roll out at a governmental level that is looking at social welfare service specifically for the elderly. Because when individuals were not able to be cared for by their family, either they had no family, or again, the family was just physically, financially unable to care for that person, they were institutionalized. And so we had to come up with a way to pay for that essentially institutionalization. So then there started to be, as I mentioned, different preparation and trials for how we manage individuals. If you see this line kind of go up, you can see that then around the 90s and really late 1980s, we started really looking at long-term care insurance. If you talk to people older than yourself, you may hear of a cancer policy. That is almost non-existent in this day and age, but essentially it was a policy that stated if you were to get cancer, it would pay for certain types of care for you. And so prior to really 1980, 1970, we did not have insurance that specifically paid out to long-term care. So as we kind of ramped up our movements in how to care for our loved ones, also these services were put into place. And now what you see, if you look around and you see a lot of assisted livings popping up and different home health care agencies, you can definitely see that there is more case management as it relates to individuals staying in their home and now looking at the caregiver who is left to be primarily responsible for caring for that person. Now this is a kind of snippet that I'd taken off the National Council on Aging, and it looks at different innovative services that have popped up in our history. I won't read them all to you, and you can pause this if you would like, just to look at the history of some of these services that have popped up based on our movement from institutionalized care or family-based care back to more of this super case management plan, where we want to integrate obviously the patient, but with a caregiver in mind, and how to keep that caregiver healthy by making sure that services are paid for and respite is provided. all of this, of course, coincides with our aging population. And as being students in a gerontology class and hopefully having gerontology classes prior to this one, you'll know that we are in an upwardly mobile phase of not just the baby boomers getting older, that is absolutely a part of it, but in general, we are living longer. So right now we are at this interesting kind of crux to where we have, specifically in the United States, the baby boomer generation that is a very wide segment of our population getting older. But in general, we as human beings are living longer. And so now we have to look at how does that work and who is going to care for us as we get older. So let's talk about caregiving a little bit. I'm going to throw out some different terminology to you as well as what was provided for you in the textbook. Just as a reminder, these lectures are supposed to be a complement to what you're reading in the textbook, and I don't necessarily lecture from the text, so hopefully all of this complements each other. So let's talk about what is caregiving. And truly, caregiving takes many different forms, and as we focus on caregiving for individuals who are older, we are looking at individuals who, even though they're getting older, many people live in their homes until they do pass away. And there is a big misnomer of people thinking that as you age, you automatically go into an assisted living or nursing facility, but statistics show us that most people do remain in their homes up until the time that they pass away. So helping other people, these caregivers typically are not just living with someone who's older, but they're living with someone who is older and chronically ill or disabled, or may have cognitive decline in other ways, such as Alzheimer's, dementia, Parkinson's. And this can be a family member or friends, and it happens maybe with a one-on-one type of care. So just an example of one type of caregiver could be a spouse, but a lot of times we see communities of caregivers coming together. So potentially spouse, adult children, and neighbors or church members or people in the community who have a close tie to that individual. And many of these helpers do not think of themselves as caregivers. So for all of you that may be going into different areas of your field, one thing that I will stress to you, and hopefully you look at it in a different way, is as you talk to caregivers, they will self-identify themselves as someone who is a spouse or a partner or a parent or a child or a friend. And actually what we want to really encourage is to have them also title themselves as a caregiver, because that is an entirely separate role from their role as being a partner and spouse. So if you look at kind of this orange line here and other things that they do, helping someone get dressed, take a shower, give medications, spending time to make plans for someone who might need to go to a doctor's appointments and do different things. If you're an adult child caring for a parent, those are not the roles that typically go along with just being an adult child. Those are the roles that go along with being a caregiver. And so it's important that we stress that to those that we work with. Who are caregivers? Sometimes I don't think this slide does any justice in terms of identifying who a caregiver might be, but obviously the ones we typically think about are a partner or a spouse, adult child, parent, other relatives. We do have several siblings that are enrolled in the research project that I've been a part of, a friend, or really anyone who provides care. And this can be someone who isn't a family member or a friend, but they're a neighbor and they just have a strong connection in that sense as well. So in terms of definitions, the one thing we don't really do is have specific questions about some of this terminology, just in terms of there is such a wide breadth of information out there as to what is a caregiver and what is the specific definition. So these are some examples. Your book provides you with another example as to what a family caregiver is and what a care recipient is. And so I won't read those to you, but provide those to you as well. And just compare and contrast as you read either different papers, and you'll see this, that people cite the definition of a caregiver from other researchers and individuals. But as you read these definitions, identify what the common theme is among these. So one thing, as I mentioned before, is to recognize family caregivers and name that they do and are very much a caregiver. They do the role of a caregiver, and they themselves are caregivers. And so if family members don't really think of themselves as caregivers, they don't really know how to look or know even to look for resources for themselves. So once we can almost label someone as being that role, as being a caregiver, then that opens up their ability to advocate for themselves, not as the adult child of their parent. In a lot of ways, our caregivers, and we will talk about this more, feel a great deal of guilt because they might be stressed and they might be strained and they feel like they shouldn't feel that way because that's their job, quote unquote. But truly, their job as a spouse is typically not to provide medication arranging services or do a lot of the things that a caregiver, truly a hands-on caregiver, does. So professionals are very much in the position of helping family members identify that this is specifically a role and what that role means to that particular individual. So a few of the challenges, and one thing I'd like you to keep in mind as you start to look at your discussion groups and potentially the discussion groups for which you are a leader in, is as you're looking for resources for your fellow classmates and to really educate them, is to look for some of these challenges that in particular spouses or informal caregivers or adult children face, or individuals who are in the LGBTQ community that are taking care of a partner. And some of these challenges, on average, regardless of that other person's role outside of being a caregiver, we do see higher morbidity and mortality rates among those individuals who've been caregivers for a long period of time. That stress and strain takes a lot of physical demands and makes a lot of physical demands on them. And going along with it, just in doing that manual labor of being a caregiver, they could have physical injuries such as back strain. We've even seen caregivers who have been trying to get someone in and out of the bath, and they themselves have slipped and fallen and broken potentially an arm or strained their ankle. So the other part of caregiving is that typically they are so worried about getting someone to their doctor's appointments and their, checkups that they forget that the caregiver themselves have their own health needs and their own health care, and they miss those appointments because in general, in comparison, they feel that their health is pretty fine. But actually, if they were to compare themselves in a similar age group to individuals who are not caregiving, their health is not that good. So they are very much juggling many roles. They can be working or taking care of their own children. You may have heard of the term the sandwich generation. What that means is you have individuals who are essentially caregiving for their own children because they're probably younger, in elementary age, or potentially even younger or a little bit older, but then they're also caregiving for their adult parents. And so they're sandwiched in between essentially two different types of caregiving roles. And we've seen that intervention has shown to decrease some of these consequences. So we want to be able to talk in this class, in this semester, about techniques and working with caregivers and their unique challenges, but also what we've seen from the evidence and the data and research that has helped these caregivers manage. The last item I have on here is sleep deprivation, and as I'm very aware that I'm talking to students, some of you with your own work schedules or family schedules, parenting schedules, we all know what it's like to be sleep deprived, and if you can imagine that sleep deprivation lasting years. For some of us who have kids, that sleep deprivation lasts months, and that's plenty of time. But for adult caregivers who are taking care of someone, it could be a roller coaster of having good days and bad days, and that can last several years. So their own sleep deprivation and what that causes for their own cognitive mindset is something to consider as well. Some of the barriers that are faced, and again, this is kind of just a tipping point this first week to get you ready for all of the information we'll be talking about over the next several weeks. But some of the barriers that are faced by caregivers is a lack of education about resources or maybe even the particular disease that their loved one is suffering from. So, for example, for an Alzheimer's patient, their behavior or mood swings can definitely change, and that can be impacted by multiple things. But if a caregiver just feels like that behavior change is going to happen and there are no interventions that I can do as a caregiver to manage that, then they would be wrong. There are different techniques, communication techniques, potentially medications that can really help in working with someone who has Alzheimer's or another type of dementia that's going through those behavior changes. Just the formal system of having to navigate calling a nurse and waiting for that office to call back or struggle to get in, or having someone hear them. A lot of times caregivers feel that as soon as they mention to a healthcare provider that their loved one has Alzheimer's, they automatically feel like the door is shut to them, and that healthcare professional on the other end is not really willing to listen to or provide some different intervention and techniques. As long as caregivers feel that healthcare professionals hear the term Alzheimer's and think, well, yeah, that's going to happen because they have that disease. That is extremely untrue, because there are many things that people can do in taking care of someone with Alzheimer's or dementia to help with some of that stress and strain in communicating with the person with Alzheimer's. So as you look at those barriers, it is important to keep in mind that all of those that pop in there, the legal concerns, finances, their own self-care barriers, maybe lack of informal supports. There's not a lot of informal supports. Isolation, we're going to talk about caregiver isolation and how very brutal that can feel in someone who potentially was very active before. Developing trust with the healthcare team. Most of the time, all of these things are happening simultaneously, and they're happening at once. Very rarely do we see caregivers who are dealing with just one of these issues or one of these barriers. Most often they're dealing with several of these at the same time. As we wrap up, and I know, especially having had a class on campus versus online, these lectures may seem very brief. But one thing I want to really focus in on is the readings that we have available to you, and hopefully how these lectures spark a conversation and may spark your desire to go online and learn about something else and share that with your class. We live in a really wonderful world of technology, and so for you to be able to take your own time and sit here and listen to me talk with you in a lecture, I like to switch it up and add different things, because I know you have a lot going on and I want to provide this to you in the most effective way possible. I'm going to leave you with this cartoon and just kind of let you sit with it for a while after I sign off, just to think about the unique challenges that caregivers have and what sometimes they really need. I'd mentioned in my introduction under the class discussion about my role and what I've participated in terms of my own research. And I can tell you, and having very recently gotten off the phone with a caregiver, it really wasn't about our ability to give her resources or give her the intervention techniques that we've developed. It was truly the ability to have someone once a month, no matter what, on the other end of a phone call that wouldn't judge her for feeling frustrated, for feeling alone, for really resenting at times her role as a caregiver and a spouse at the same time. So it's important that we keep these things in mind as we contemplate different interventions for caregivers, because obviously education is a big part of it, but sometimes it just takes a little bit of time from us to them. I hope you enjoyed this very brief 20-minute lecture, and I look forward to this semester. I'm truly passionate about working with caregivers and kind of looking at this epidemic as it really has become. So thank you so much for your time, and I look forward to the rest of the class.